So building on the theme of patient-reported outcome measures, I'm going to talk a little bit about what has been pretty much the last decade of work that I've been embarking upon. And when someone says to develop a new measure takes about 10 years of work, it has been that and then some, because the work continues. I'm going to talk a little bit about the experience of developing a patient-reported outcome measure called the HIV Disability Questionnaire, the development and property assessment, some of the lessons learned that we've had with the HDQ, both implementing it and evaluating its properties to date, and some of the next steps that are being done in the field. So developing a patient-reported outcome measure. As we know, adults are living longer and aging with HIV, and the potential consequences not only of HIV itself, chronic inflammation, multimorbidity, and aging can result in these health-related challenges. And as a physiotherapist and the field of rehabilitation, we often conceptualize those health-related challenges as disability. And this disability can be experienced, as we've seen today, as multidimensional and episodic in nature. Measuring the concept of disability is really important for a number of reasons. First, as a screening tool to describe and better understand the health-related challenges that patients might experience. Measuring disability can help facilitate timely and appropriate referrals to services, facilitate patient-centered care, and that involves facilitating a communication between patient and provider, assisting with goal setting, and communication among the team members as well, which we've seen some great examples of what's being done clinically here in the UK. And they can also help to evaluate the change and demonstrate effectiveness of particular interventions in rehabilitation. But at this stage of the game, when I was starting out, there was the nature and extent of patient-reported outcomes that captured disability experienced by adults living with HIV was unknown. So I learned, given my training in clinical epidemiology, when you're embarking upon the field of measurement, the first rule is to know very clearly what is the concept that you want to measure. And in what target population are you interested in measuring that concept, and for what purpose? Is it to describe a particular health state, to evaluate a change in someone's status over time, or to predict a future event? So in my PhD, I embarked upon defining the concept of disability, and that was essentially the concept I was very much interested in learning how to develop or measure down the road. And I conducted a series of focus groups and interviews with men and women living with HIV in the Toronto area, asking them about their health-related challenges and the impact on their overall life. From this work emerged a conceptual framework of what we termed episodic disability, and it had a few components. The first was these dimensions of episodic disability, and it included symptoms and impairments like physical, cognitive, mental, and emotional health challenges attributed to HIV, side effects of treatment, for example, stress, anxiety, and depression, and emotional health challenges such as fear, decreased self-esteem, shame, embarrassment, or even loneliness. A second dimension of disability were difficulties with day-to-day activities, such as basic grocery shopping, dressing, feeding, bathing. And then moving on to the pink here, we have challenges to social inclusion. So difficulty fulfilling one's role as a parent, engaging in work and school, embarking upon new or sustaining existing personal relationships, and adopting other social roles and activities, for example, travel or leisure. The first three are very ICF-oriented and very familiar to us in the rehabilitation world, but it's the fourth dimension that we hadn't anticipated that came forward in this qualitative work called uncertainty and worrying about the future. Participants in this work talked about how they worried about when their next episode of illness might arise, how severe it might be, and what the consequences of that episode might be. In addition to the dimensions of disability, another component of this framework were the contextual factors. So there's all the stuff that goes on in one's environment, as well as intrinsically within an individual, that could exacerbate or alleviate any of these episodes of disability over time. For example, the nature of social support one might have from friends, family, partners, pets, the community, healthcare providers, or program and policy support. Stigma, which we talked about this morning as an exacerbator of episodes of disability. And then intrinsically, there were many living strategies that participants talked about, the things that they did in their day-to-day lives, such as seeking social interactions with others, maintaining a sense of control over life, maintaining attitudes of positivity, hope, and optimism, or just trying to block the fact that they're living with HIV out of their mind altogether as a way to deal with the day-to-day challenges. And then we also have the non-modifiable factors when it comes to age and some of the age-related issues that were popping up with respect to the participants' health challenges. So when embarking upon these interviews and focus groups, I really avoided using the term disability altogether because it's quite a loaded term for many individuals and means different things in different contexts. But at the very end of these interviews and focus groups, I asked what that term meant to individuals as it related to living with HIV. And there was a real love-hate relationship with this term. This one participant talked about how disability alone was perceived inaccurate because it suggested permanency. And participants reported, however, having to accept what they saw, this term as being a label in some instances, in order to access needed services. So this one participant talked about being part-time disabled and being a reality that she sometimes had to accept. Not all days, but on some days, and she accepted this concept of being part-time disabled once in a while. So this concept or term of episodic disability emerged as being something more accurate, perhaps, in attributing to their health challenges. The question being is this concept of episodic disability unique to HIV or experienced also similarly across other chronic conditions that we've heard from today? This is just an example of what one individual's experience might be living with HIV over time. You have the major episodes or fluctuations in health, and then superimposed upon those are the good days and bad days that an individual might experience. And then among those are all those contextual factors, both intrinsic and extrinsic, that might exacerbate or alleviate episodes of disability over time. So now we have the definition of disability, defined as any physical, cognitive, mental, and emotional symptom and impairment, difficulties carrying out day-to-day activities, challenges to social inclusion, and uncertainty. So that definition, including those components of our dimensions of disability. But I remember a member of my thesis committee saying at the time, does the world really need another outcome measure? And before you go about developing a new measure, you want to make darn sure that there isn't anything existing out there that can accurately capture the concept that you're interested in measuring with this population. So I took that conceptual framework of episodic disability and I looked at the literature and looked at a number of HIV-specific health status instruments that were out there in the field. At the time, there were 30 that met our inclusion criteria, and I did a content analysis looking at the 72 categories that were part of this framework and mapped them onto the items in these existing questionnaires. And what we found is that the measures did a pretty good job of capturing symptoms and impairments, particularly the ones around physical symptoms, around fatigue and weakness, headaches, for example. Pretty good job at capturing basic activities of daily living. But where they didn't do so well was when it came to challenges to social inclusion, and very few, if any, included any items that talked about uncertainty or worrying about the future. So from there, we moved forward to have a rationale to move forward to go from a conceptual framework to actually developing a patient-reported outcome measure. So we were struck with how we actually go about this. And I was very fortunate in my PhD and then moving on to my postdoc, which is where we're getting into the work here that I did with Patty Solomon at McMaster University, moving from the qualitative work to now the outcome measure development, and working and collaborating with a very engaged community advisory committee that were integral to developing the items and refining this questionnaire that came about. The community advisory committee included 2 adults living with HIV, an employee of an AIDS service organization, and a representative from our Ontario Ministry of Health and Long-Term Care. We had a number of individual consultations, but 2 meetings in particular where we talked about item generation, going from the categories in this conceptual framework to the actual measure. We had extensive discussions around phrasing, the order of questions, response options, the instructions to the questionnaire. How were we going to tackle measuring episodic disability with a questionnaire that may be administered just at one point in time? What about domain order? And what kind of time frame are we going to be asking about these experiences of disability among participants? The community engaged approach was really integral to item generation, And members of the Community Advisory Committee actually generated a couple of items that weren't captured in the framework. In particular was one item around worrying about criminalization with HIV transmission, which was particularly pertinent to us in Canada, and the ability for individuals to ensure safe and secure housing. So these were a couple of items that we added to the questionnaire, not included in the framework. This community-engaged approach enhanced the questionnaires' relevance, feasibility, face, and content validity. We then moved to a study looking at assessing the sensibility of the questionnaire. We administered the tool to 22 adults living with HIV and 5 clinicians who work in HIV care, followed by an interview. And participants spoke about their experience with respect to content, face validity, ease of usage, and format. And we used the results from this work to further refine the HIV disability questionnaire. So what resulted was a questionnaire, self-reported in nature. It consisted of 72 items that asked individuals about their health-related challenges on that given day. And then for each of those health challenges, there's an episodic question that asks whether that challenge fluctuated at all in the past week. And that could mean it got better, it got worse, or maybe it did a little bit of both. And there was one final question that we added, asking individuals to report whether they thought they were completing this questionnaire on what they would consider a good day living with HIV or what they would consider a bad or a challenging day living with HIV. Now, if you think back to the conceptual framework of episodic disability, we had 4 dimensions of disability. But when we're moving to the questionnaire development, we weren't quite sure, well, what's this domain structure? Maybe it's 4 domains, maybe it's more. So what we did was an exploratory factor analysis to try to establish what the domain structure of this questionnaire would be. We administered the tool to 361 adults living with HIV in the Toronto area, and we found that there were some items where individuals had very little health challenges, so there was a floor effect where participants tended to rate 0 or having no challenges at all. And then there were some items, particularly in the uncertainty domain, that tended to have a ceiling effect where many participants maxed out, saying that they had extremely high challenges when it came to uncertainty. And we had a 7-point response option here, and we found that very few respondents were responding 2 or 4. And you'll notice here that these are the 2 response options that don't really have any word descriptors associated with them. So we made further refinements. We went from a 7 response option scale down to a 5 option scale. And the results of our exploratory factor analysis tended to suggest that there are actually 6 domains in this questionnaire. There's a physical domain, a cognitive domain, one particularly around items that address mental and emotional health challenges, difficulties with day-to-day activity, uncertainty, and then this social factor that asked a lot about relationships and social inclusion. So we went back to the Community Advisory Committee and we made some tweaks. We removed a few items, one around gaining weight that didn't correlate with any other items, one around constipation, and one about worrying when my next illness might arise, because it tended to have very similar correlations with other items in the tool. We moved a few items down around different domains, and essentially we landed on this. The HIV Disability Questionnaire, which consists of 69 items across these 6 domains, and you can see the number of items in each of the domains with a 5-point response option scale, and then you have here your episodic scale, asking whether that challenge fluctuated in the past week, yes or no. We went from 72 items to 69 items. Mental note, not a whole lot of item reduction. But what we did was we plugged along and we looked at the measurement properties. So we wanted to assess how valid and consistent or reliable this tool was at measuring disability. We conducted a confirmatory factor analysis, mapping or forcing the items that we thought should map on each of those 6 domains. And the results were that yes, the HDQ had demonstrated construct validity among adults living with HIV. The correlations between the dimensions of disability ranged anywhere from 0.53 up to 0.8 between mental and emotional health challenges and social inclusion. And we had the ability to validate this tool not only in Canada, but also in collaboration with St. James's Hospital and a cohort of 96 adults living with HIV accessing the guide clinic there. which similarly demonstrated construct and test-retest reliability among adults living with HIV. This slide demonstrates what some of the scores actually looked like. So the HDQ is scored, there's a presence, severity, and an episodic scale ranging from 0 to 100. Higher scores indicate greater presence and severity of disability. And looking at both older and younger adults in this particular sample, this was with 941 Canadians living with HIV that completed the questionnaire on a web-based survey. The highest domain scores for both presence and severity were on this uncertainty and worrying about the future domain. And compared to younger adults, there were higher physical health challenges and difficulties with day-to-day activities seen among the older adults in this sample, and higher presence and severity scores for uncertainty among the younger participants. Among the challenges that tended to fluctuate within that current week, the most common health-related challenges that tended to fluctuate tended to be in those physical and the mental and emotional health domains here. So we've implemented the HDQ, we've assessed some of its measurement properties, but the question is it really valid and reliable in other contexts? The HDQ has since had the ability to be administered among Canadians living with HIV through this web-based HIV Health and Rehabilitation Survey, in Dublin with the work that we did with St. James's Hospital there, also with a sample living with HIV and peripheral neuropathy in the United States, and most recently with a sample of adults living with HIV accessing the Dean Street clinic with here in the UK of 243 participants, and this work's being done with Darren Brown. And so just leading up to today's presentation, we've actually put those 4 different samples together to kind of get a snapshot of where people across these 4 samples are experiencing with respect to presence and severity scores. And consistently, uncertainty is the highest presence and severity scores across all 4 samples. And this is both for presence and severity. And you can see here that the Canadian and the US samples tend to have consistently higher HDQ presence and severity scores. And the caveat there being that we recruited for our Canadian study largely from community-based AIDS service organizations, so participants were identified as having health-related challenges. In the United States, those were individuals living with HIV and peripheral neuropathy, so we may expect that they had higher presence and severity of disability. In Dublin and also here in the UK, the HDQ is administered in an HIV clinic. So we may speculate that individuals there may be sort of living well in some respects and have less health-related challenges. So it kind of speaks to the methodology, and really going back to, you know, how you recruit participants for your work really has an influence and in terms of how your results play out. We did some structural equation modeling with the HDQ scores in our Canadian sample. The take-home message here is that uncertainty is a key component of disability. It is a strong predictor of having mental and emotional health challenges, and as well a strong direct and indirect predictor of having challenges to social inclusion. So here are some of the lessons learned in the next steps. Development of this tool has been iterative, and the HDQ is far from perfect. What we've done after we established the HDQ, the work done at McMaster University in my postdoc, and then since has continued in my role at University of Toronto, is we wanted to actually set up this HDQ to be broadly used by researchers but also by clinicians. So after numerous meetings and back and forth, we developed a user agreement that is posted on the McMaster website, where individuals can click on, read this user agreement, and request the HDQ for use either in research or clinical practice. And with the caveat that individuals are prohibited from modifying, adapting, or translating, or making derivative works of the HDQ. And it is free. There's no cost to use the HDQ if used in an academic setting or in a trainee setting, with the caveat of signing up for this user agreement. So one of the things that we've learned is managing the requests to adapt the HDQ. There have been a few to date, and really being clear about what the concept of disability is and what this tool was developed. And I say disability creep here because there's a lot of those interesting influencing contextual factors like stigma and social support and coping that definitely influence disability. But we've had to be very clear in our scope that the HDQ is about measuring the concept of disability. And those other contextual factors are very important. And then when administering the HDQ, it's perhaps important to consider about administering other patient-reported outcome measures that capture those other very important elements as well. We've also received feedback from community about the positive versus negative wording. So disability being perhaps negatively termed because we're asking about health challenges. And again, going back to the development of the episodic disability framework and being really clear about what the HDQ does and what it doesn't do. And it is a measure of health-related challenges, and it is a measure of disability. So the HDQ has been administered clinically. For Casey House is a specialty HIV hospital in Toronto, and they've recently launched a day health program there with a physiotherapist who administered the HDQ to 29 adults living with HIV, a mean of 56 years with 5 concurrent health conditions. And it's been a very different scenario administering the HDQ in a clinic setting versus a research setting. Research-wise, when we assessed validity, it was taking individuals about 11 minutes to complete. Clinically, it's taking 30 minutes to an hour. And that's because it becomes a conversation and a back and forth between patient and provider. There's a lot of discussion around goal setting, for example. So the providers and patients at Casey House have indicated there's a lot of value to the HDQ, facilitating referrals, goal setting, and communication. But hey, we really need a short form to reduce any patient and provider burden and to really facilitate the timely use of this tool in the clinical setting. So that's part of the next steps and part of my work and collaborations here with Richard and the team at King's College London is to actually look at ways to develop a short form for the HDQ and using different measurement approaches such as rash analysis in order to reduce those items of the questionnaire. We are currently, through our community-based exercise intervention study that's going on in Toronto, looking at interpretability and responsiveness. So for example, what does a score of 60 versus 20 on the HDQ really mean? And is the HDQ really good at picking up changes in disability when change truly occurs? Future steps down the road, I think it would be really fascinating to see the HDQ being used as a computer adaptive test or tool, and to be more broadly implemented into clinical use to facilitate referrals and get immediate scoring back in real time to help inform clinical decisions. In the meantime, because it's a long haul in developing and refining these measures, what can we be doing in practice? The simple form is just asking what domains of disability your patients might experience. And are those domains, or is that disability being experienced as episodic in nature? Does it fluctuate daily? Does it fluctuate even differently during the course of the day? And how are those episodes triggered? What's the impact of disability on your overall health? And what contextual factors might exacerbate or alleviate those episodes of disability? And lastly, are there any community-based services or rehabilitation interventions that might help to mitigate or even prevent disability in the future? So some of our lessons learned in conclusion is that patient-reported outcome development has been an iterative process. It's very population and context specific and very much depends on the representativeness of your sample. The community-engaged approach has been critical for development, assessment, and extremely rewarding in terms of the long-standing collaborations there as well. The administration of the HDQ, some of the caveats to think about is the conversation that needs to happen pre and post administration, being very clear about the HDQ, what it does and what it doesn't do. For example, it doesn't, quote, label someone as disabled or not disabled. It's purely a descriptive tool to highlight what the health-related challenges are and what areas of life those might occur. And the importance of pairing the HDQ with other contextual factor outcome measures. So I think there's a lot of opportunity here with our CURC collaborations and the interest and expertise going on in the room in advancing patient-reported outcome measures as a key research priority in the field of rehabilitation and across chronic disease. So lastly, I'd just like to acknowledge a number of individuals who have been involved in this work over the years in the episodic disability framework as well as the HDQ development and assessment. and acknowledgements also to the funding with the British Academy and many of the collaborations and support for this work and today's symposium as well. So thank you.